Okay, gang, so video is going to cover the basics of how a heart actually beats, which is referred to as the cardiac conduction system. And we will also take a look at a couple of EKGs or ECGs and look at what the blips on those graphs actually mean in terms of how the heart is actually beating. We'll take a peek at a couple common arrhythmias as well and talk quickly about pacemakers. So let's jump right into it. So in front of you here, you got a picture of cardiac muscle tissue, right? So you've got a whole bunch of different cells. Particularly, this is probably the easiest diagram to look at it from that standpoint. In terms of structure, it's still actin and myosin, just like we saw with the muscular system, guys. It's very, very similar. There's only a couple small, slight differences in the way it contracts. You still have myosin heads reaching out for the actin, trying to grab hold. They're still blocked by the troponin and the tropomyosin. You still need calcium to be released, and that calcium then removes those out of the way so the myosin heads can grab hold. All of that stuff still stands true. What we have is two real big differences. The first real big difference is that each of these cardiac muscle cells are display what's called autorhythmicity. And what this term autorhythmicity means here is that those cells can actually reach threshold by themselves. They don't need a neurotransmitter to come bind to them to get that muscle fiber impulse and then to let in a little bit of calcium. Essentially, what's going on in autorhythmicity is you get a slow leakage towards threshold. Right? So the threshold in this case is around negative 40 millivolts. The numbers don't make any difference for us, guys. We're not interested in that. But you get a slow leakage, and what happens is it will slowly leak, hit threshold, and then you get a muscle contraction, and it can reset, and it'll do that. So all of these cells have their own kind of pace built into them, and you've got like an internal pacemaker and all that kind of stuff. And we'll get into some of the details there. The second big idea that you want to have is that they each have kind of their own depolarization phase. So this actually varies quite a bit. So for instance, the part we're going to focus on is called the sinoatrial node. It's kind of right up here in the top part of the heart. That depolarizes the fastest. And because it depolarizes the fastest, it tends to set the pace for the entire heart. And the AV node depolarizes a little bit slower. So if something happened for the SA node, we would then take over this rate. And if something happened to both of those parts, or they were no longer connected, we'll show you in a minute, all of these different parts of the heart down here have even a little bit slower rate to them. But all of them are autorhythmic, and they can also, or sometimes you'll see automaticity, you'll see that phrase as well, but that's kind of what you're looking at here. The last big concept before we actually get into how the heart beats is we want to talk about with the cells. The cells, when we were talking about skeletal muscle fibers, if this muscle fiber right here had a muscle contraction, it didn't mean that any other cell contracted. They each had to be stimulated individually. In this case, what happens is the electrical signal spreads. So in cardiac muscle tissue, if this one contracts, all of this contracts. So one little cell here contracting spreads, and the entire muscle fiber is going to contract. The entire muscle, all the muscle fibers that are attached will contract. That was part of those gap junctions, the connecting junctions, and how they're actually held together. But that's a big factor. So once one part of the heart reaches threshold, the electrical wave is going to spread, and the entire heart is ultimately going to contract. And that's a huge idea when we get into this. Okay, so you guys have this sheet as a handout, along with some other vocab you're going to be defining throughout here. But this sheet actually runs through how the muscle actually contracts. So we start off, as we've already kind of mentioned once before, we have this SA node at the top. It's called the sinoatrial node. SA is just fine, guys. And the sinoatrial node is the heart's natural pacemaker. So if you wanted to jot that down in there someplace, guys, that is the natural pacemaker of the heart. It reaches threshold. It depolarizes towards threshold faster than any of the other parts. When it reaches threshold, the electrical wave spreads. Remember, we just talked about this, the fact that the muscle cells are connected in a way that the electrical wave spreads from cell to cell. So once we reach threshold here, the entire top part of the heart is going to reach threshold and contract. Right? So reaching threshold ultimately means calcium release from the sarcoplasmic reticulum, and the troponin and the tropomyosin moving out of the way, and the myosin grabbing the actin, and then we get a contraction. Okay? Now, the thing that's interesting is the bottom half of the heart is electrically insulated. So the atria that are at the top will contract, but there's a barrier, so that electrical wave can't spread down to the bottom. So you get the top part of the heart contracting, and that means we now pump blood from the atria down into the ventricles. Right? While that blood is going down there, we will get the second part of the contraction. And what happens in the second part of the contraction is the signal, the electrical wave, goes to this AV node here, right? And we're going to go up to here. So the AV node has a little built-in delay. And the delay is really important, guys. You need to be able to fill the ventricles before the electrical wave gets there. Okay, so we have a delay as it hits the AV node, passes down the septum, still having a delay, and then when it reaches the bottom here and hits the apex, now the electrical wave spreads to the ventricles, and the ventricles contract. So what you actually end up, and there's all sorts of vocab in here, guys. They're called the Purkinje fibers that kind of go through here. I don't mess much with that, guys. I really want to stress these pieces. That we start, the signal starts at the SA node, okay? It's the pacemaker reaches threshold first. That electrical wave spreads to both the atria, so the atria are going to contract, but not the ventricles because they're electrically insulated. They have a wall of connective tissue keeping them apart, okay? Then it passes that signal on to that AV node, and there's a little delay as the AV node gets going and sends the signal down the septum. And it's not till we reach all the way down, remember the septum is the wall between the two ventricles, it's not till we reach the very bottom here, this apex, the tip of the heart, that's when the signal will actually spread to the ventricles, and the ventricles will begin to contract, and you will finish the contraction. Okay. So a couple things that I think are really cool about this process, guys. We ultimately get one signal that starts in one location, and that signal controls really two separate contractions. We get the top part of the heart contracting, and then the bottom part. Okay. We get a built-in delay, which is really important. So that as that signal goes down that septum there, as the signal is going down that septum, we have this great delay. And that delay is important because you got to be able to fill the ventricles all the way before you squeeze them, before you squeeze the blood out through the aorta and the pulmonary artery. All right. And the other thing that I think is really cool is the directionality. If you think about where this starts, guys, the atria, this contraction starts at the top and it spreads kind of like this. So the ventricles the atria contract kind of top down. So they squeeze the blood downward, right? And when the ventricles contract, they start way at the bottom and they kind of make their way upward, and that squeezes the blood up and out. So you actually get one electrical signal that causes not only two separate contractions, but two separate contractions that are kind of aimed in opposite directions with a perfect built-in delay between them. So I think it's a really cool process. Hopefully you kind of appreciate how cool it is. All right, and the last two things I want to talk about before we move on are two vocab words that I want you to be familiar with. So systole refers to contraction. All right, so if you see the phrase atrial systole, that means the atria are contracting, or the ventricular systole, the ventricles are contracting. Okay, diastole is kind of the relaxing. So after you squeeze all the blood out of a certain area, the muscles have to kind of relax and kind of reset, electrically reset, and kind of relax in size and shape, and that's the diastole. So you've got those two words that you want to be able to kind of recognize. Think of them as contraction, relaxation. Okay, and that's the two of them. Okay, and you'll hear these. Those of you guys like your medical shows, you'll hear like asystole all the time. That means there is no, A is without contraction. So that means the heart is no longer beating, and you'll hear that in a lot of your medical shows. All right, so contraction, relaxation. All right, so on this page, guys, you see a common EKG or an ECG. It stands for electrocardiogram. And cardio in a lot of places spelled with a K, so it's electrocardiogram, EKG. We've kind of started forcing everybody to call it an ECG for cardio the way we say it. But what this does is this shows the electrical activity of the heart. And so if you break this down, what's actually going on with the heart, the very first electrical activity you get in the heart is the a little technical difficulty there for a second. So we get this first electrical activity right here. That's the atria contracting. That's the atria have been stimulated. They have reached threshold. The SA node has reached threshold. The electrical wave is spreading across the atria, and the atria are contracting and squeezing the blood into the ventricles. And then, right in between there, you have a delay. Right? See that flat line where there's nothing going on? That's that electrical wave making its way down the septum. So it's hit the AV node, it's going down the septum, and there's delay. And then what's referred to as the QRS complex, that big spike there, is a representation of two things, really. It's primarily the ventricles contracting, but also the atria kind of relaxing, going back into diastole. Okay? So you get the atria contracting, a delay, ventricles contract, they squeeze the blood out to the body, and then there's a little delay, and then this is the ventricles resetting. Okay, so that's an entire heartbeat with the atria contracting, and then a delay, ventricles contracting, and then a delay, and then the reset. And then this would be the time between heartbeats. Okay, and that's the number one thing that'll change when somebody's heart rate goes up or down. This gap will shorten if somebody's heart rate goes up. You can also see a couple other spots, like you'll see the delay here between the S and the T can actually drop, and you can see a couple different spots. But the biggest thing is this drop gap here, and that if that gets smaller, then you get more beats per minute as a result. So, segueing from that idea, how would we actually speed up the heart rate? Well, we have a nerve that connects right here, the vagus nerve, and if you cut that nerve, your heart will still beat, a nice steady beat for your whole life, because the SA node can reach threshold, but you can speed that up or slow that down as we wish. So if the sympathetic nervous system kicks in, that's our emergency, our fight or flight, we will release essentially adrenaline at that spot, and that norepinephrine and all that stuff will cause a greater kind of slope there. So we'll reach threshold faster, and we'll get heartbeats that are closer together. Right? If it's the parasympathetic that gets released here, so we release another neurotransmitter, we release ACH, and what that does is slow things down. It makes this slope kind of go more like this. So you might get a longer gap between heartbeats. Okay, so it can beat without either of those stimulations in there, but we commonly speed it up or slow it down to meet our purposes. Okay, if it speeds up really fast, we refer to that as tachycardia, and if it slows down, it's referred to as bradycardia. Let me write those on here for you. So here are those two words. So tachycardia is a elevated heart rate, and bradycardia is a lowered heart rate. Usually bradycardia is someplace between below 60 beats a minute. That's kind of the threshold that most people associate it, and tachycardia is usually upwards of 100. So between those two is kind of your normal range, and both those things happen, right? You start exercising, you go into tachycardia, it's not a big deal, and when you're sleeping, most of us will probably slip into bradycardia, but if somebody were slipping down to 30 beats a minute or something along those lines, that might be an indicator of something really bad. Or if they're sitting at rest and if they're at tachycardia, that's an indicator that something's weird. So those numbers should make sense with what you're doing at the time. All right, so I just wanted to show you a couple other common arrhythmias, conditions where the heart isn't actually beating on a steady rhythm as you might expect. So the top one here, you'll see a normal heart rate. That's a piece of cake, right? So you've got your atria contracting, ventricle contracting, resetting everything, atria contracting, ventricle contracting, resetting everything, and it repeats at a nice rate. Okay. And the second one, if you look at it, we've got a normal heartbeat. Okay. And then what you get here is you get a second, not really a second, I'm sorry, kind of misspoke there. Notice that this delay is longer. So when somebody actually refers to a heart blockage and they're talking about electrical activity, what they're talking about usually is the signal's having a hard time getting down that septum. So remember, when you got your diagram of your heart, you've got the two atria up top, you got your two ventricles down bottom, and the SA node sits right here, and the atria contract, and then the signal's supposed to go down the septum and then spread to the two ventricles down here. if for some reason this is blocked, okay, or the signal goes slower, that's what we refer to as a heart blockage, okay? So in this case, the signal's going slow, it's not getting down at the normal rate, all right? So that's a first degree heart blockage. And a second degree block, they often refer to it as a 2-1 block. This made more sense to me. You'll notice you get a contraction here that looks pretty good. And then here, the atria contract, and then nothing happens. The signal never got to the ventricles, and the ventricles didn't contract. And then the heart tries again, atria contracts, oh, now it works. And then here we go. So essentially, this person is missing every other ventricle contraction. Remember, the ventricles are what matters. The atria don't do very much. They just fill the ventricles. The ventricles are pumping the blood to your entire body and to your lungs. So without this ventricle contraction, this person is literally pumping half as much blood as the person above them. All right, so this is a big problem. Okay, and in a third degree block, it's gotten even worse. We get a normal contraction, then it tries again. Here's an atria with no ventricle contraction following it. And then it tries again, nothing happens, tries again, nothing happens, and then all of a sudden, here we go. And in this case, there's no connection to them at all. Remember that all of the muscle cells of the heart have their own pace, and in this case, the atria are beating at their pace, and the ventricles beating at its own pace. And you won't see really any big connection between them. Okay? So, heart blockage is usually different from what we talk about with like the fat building up in the walls of the arteries called atherosclerosis. We'll see that later on in the unit. But we're when you use that phrase, heart blockage is usually electrical activity. And to fix this, it'll be pretty simple. You put a pacemaker in, and a pacemaker will essentially time it up. It'll shock the top part of the heart so the atria contract, and then shock the bottom part of the heart so the ventricles contract. So you'll have a little electrical lead there, it's a little battery. And remember, once you shock one part, the electrical wave spreads, because that's what these muscle cells do. So in a pacemaker, you'll actually just shock the top, a little tiny delay, shock the bottom, top, bottom, top, bottom. That'll adjust the heart rate and control the heart rate. Okay, and the last concept I wanted to get in to you guys in this video, guys, is something referred to as fibrillation. You'll hear that phrase a lot. And on the left, you have your normal electrical activity. So here's your ready. So we reach threshold, electrical wave spreads, the atria contract, hits this AV node, there's a delay as the signal goes down, delay, 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 delay. Now the ventricles contract, so you get the two parts of the contraction, the dun, 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 dun. Two pieces there contracting, right? And ventricular fibrillation, you've damaged the electrical activity here. So the top part contracts, it spreads, okay? But when the signal gets down here, you have a contraction here, and essentially it's uncoordinated. Instead of one electrical wave spreading through the heart the way we normally get it, one part is relaxing, one part's contracting, and the electrical signal is almost taking this kind of maze through here. So it's stimulating here, and then it's going to stimulate here, and then it's going to stimulate here, and then here. So it's uncoordinated, and because of that, the heart doesn't really fill. All of it's kind of, the ventricles are kind of contracting at all times. It's hard to get blood into them when they're filling, and they're not synchronized and not squeezing blood out. So you're not really actually circulating blood during fibrillation. And the EKG looks like this. Look at this mess here. Okay, there's lots of electrical activity going on, but there's no organization to it. I have a friend that is a doctor, and he was in a surgery when he saw a heart go into fibrillation, and he said the entire thing looked like there was like snakes crawling around inside the heart. It was just like quivering and kind of like writhing around, but with no rhythm to it. And we'll see in a couple of videos that we're going to watch. It's got a nice, simple, organized relax, fill, squeeze, relax, fill, squeeze pattern. And without that pattern, you don't circulate the blood. Okay, so ventricular fibrillation would result in no blood really being sent around the body. And this is when they will try and use those electrical paddles to shock the heart back into a normal rhythm. So if you can shock the heart, the idea is you can make the entire thing go into one big contraction together. So if you can make the entire thing contract together, then the sinoatrial node, the SA node, might take over again, and you might get a contraction with the delay and then the contraction at the bottom. Okay, so that's the idea between that, and it works sometimes and sometimes it doesn't. But that's what they're looking at. If you've ever used one of those, defibrillators is what they're referred to as defibrillators. All right, because they're going to stop fibrillation. They actually take an EKG to start with. So the first thing it does is it actually looks. you put on the little pads, and it takes an EKG to find out if this is what's going on. Because if it's not, if there's something else going on, you don't want to shock the heart. You can mess up the rhythm. You can actually make it worse. You only want to use those things at the right time. And they're actually kind of foolproof. So if you ever feel like you need somebody collapses, I collapse in class, and there's a defibrillator there, you could try using it. It's only going to let you use it if it's in a scenario where it would actually be helpful. It doesn't allow you to shock. You can't go up and shock somebody and actually do any damage. The only time it'll work is if somebody's heart is not pumping any blood because they're in fibrillation. So, well, if you have any questions, make sure you circle them. Make sure you filled in all the vocab that goes along with this sheet, guys. And I'll see you in class.